Do you know what's the cardiac arrhythmia bypass? So if you're in residency, medical school, or even fellowship, and you're struggling to remember the antiarrhythmic drugs, let's break it down very simple. So if you take a look, there's even a modernized classification of cardiac arrhythmic drugs. They always talk about Vaughan Williams. Basically in the 70s, he developed the class 1, 2, 3, and 4 classification, which groups the antiarrhythmic drugs into sodium blockade, beta blockers, potassium blockers, and calcium channel blockers. It's easy to remember, it's very helpful, but sometimes it still gets confusing. There's even the Sicilian gambit. They had like a meeting in Sicily and they came up with another classification system, which is even more complex. Now they even have like class 0, which is ivermectin, class 1, they're adding, now they're all the way through class 7. So let's break it down very simple with the cardiac arrhythmia bypass. The first thing I want you guys to draw is a heart. And say cardiac arrhythmia bypass. At the top, we have the atria. At the bottom, we have the ventricles. At the middle, we're going to have some drugs that are going to work on both the atria and the ventricles. So what's the cardiac arrhythmia bypass? Basically, they are the class 1 sodium channel blockers. Class 1C, you're going to use it primarily for atrial arrhythmias. Class 1B, you're going to use it primarily for ventricular arrhythmia. And class 1A, you can use it sometimes for both. There are some exceptions, but that's the global concept. Class 3, there are some drugs that you can use for atrial, and there are some drugs that can act on both atrial and ventricular arrhythmia. So these are anti-arrhythmics, but we have rate control agents, like for example, the new class 0, which is ivermectin with the funny sodium channels. We have class 2, which are the beta blockers, and we have class 4, which are the calcium channel blockers, but they primarily work on rate control. There was this trial, which was the cardiac arrhythmia suppression trial. It was basically designed to say, okay, a patient had an MI, can we give class 1C agents in order to stop or decrease the risk of these patients developing arrhythmias? So the conclusion was there was an excess of deaths due to arrhythmia and deaths due to shock after acute recurrent myocardial infarctions in patients treated with enkinamide and flecainide. So they basically said, yeah, these medications we cannot use in patients with coronary artery disease or cardiomyopathies. So that's one of the most important things. So in class 1C agents, we have propafenone, and we have flecainide. They are contraindicated in patients with coronary artery disease or cardiomyopathies based on the CAST trial. So just remember class 1C, the C for CAST trial, to remember that they tried class 1C agents after MI and basically mortality increased. This is why these medications are contraindicated in patients who have coronary artery disease and also cardiomyopathy. What's the other class? Class 1A. Here we have quinidine, which is using Brugada, and it can cause GI side effects, diarrhea. We have procainamide, which is used in Wolff Parkinson White. I remember the P for procainamide. And it can cause agranulocytosis as a side effect and drug-induced lupus. They love that question. The other medication for the class 1A, disopyramide, which is using HOCM, and it can cause anticholinergic side effects. And I always remember the class 1A, agranulocytosis, anticholinergic side effects, to remember that they can cause those side effects. And always remember the drug-induced lupus for procainamide. The other class, class 1B, you have lidocaine, and I always remember you need a line for lidocaine, so that's IV, and mexiletine, which is oral. You need a mouth, mouth. And they cause basically CNS side effects. And I always remember B for brain, to remember that they can cause CNS side effects. This is more for step 1 people. They can ask you which one of the class 1 anti-arrhythmics has the strongest grip. So basically, if we take this format, the cardiac arrhythmia bypass, and we graph it, we see that class 1C is stronger than class 1A, and class 1A is stronger than class 1B. So the strongest grip is going to be your class 1C, the moderate grip to the sodium channel is going to be the class 1A, and the weakest grip to the sodium channel is going to be class 1B. That's more for the step 1 folks, but it's something that they like to ask. Another thing is, okay, so those are the sodium channel blockers. We use the cardiac arrhythmia bypass. We know that if you have an atrial fibrillation, I'm going to use one of the class 1C. We know that if you have a ventricular fibrillation or ventricular tachycardia, particularly after MI, you're going to use a class 1B. Where are the class 3? Class 3, which are the potassium channel blockers, some of them are going to act on the atria, and some of them are going to act on both the atria and the ventricles. The ones that are just going to work on the atria are going to be dofetilide, ibutylide. Amiodarone and sotalol, they can act on both. The nuclear bomb of anti-arrhythmics is amiodarone. The issue with amiodarone is the iodine moiety, which causes a lot of side effects. Pulmonary, thyroid, can cause hypo and hyperthyroidism. It has many side effects. So there's a medication called dronedarone, which is similar to amiodarone, a little bit less efficacious, but it doesn't have the iodine moiety. So it doesn't cause those bad side effects that amiodarone causes. The only issue with dronedarone is that it's contraindicated in New York HA class 3 and 4, and you cannot use this medication if you had a recent CHF exacerbation in the preceding 4 weeks. Where are the other agents? Class 0, which is your ibraverdine with the funny sodium channels. Class 2 and class 4, which are the class 2 beta blockers and class 4 calcium channel blockers. These three classes, 0, 2, and 4, they are used for rate control, not rhythm control. Okay? So remember, you have your beta blockers class 2, and with your calcium channel blockers, there's a little thing here. You see the 4, it looks like an LV. That is what I used to remember, that you have to be careful with left ventricular dysfunction. If a patient has left ventricular dysfunction, calcium channel blockers are contraindicated. So let's go back a little bit. We have the Vaughan Williams classification from the 1970s. He basically classified antiarrhythmic drugs into class 1, which are the sodium, class 2, beta blockers, class 3, potassium channel blockers, and class 4, calcium channel blockers. There are new modernized versions of the Vaughan Williams classification, and they added the class 0, which is going to be ibraverdine. And there are new classes like class 6, class 7. We're not going to get into those. And basically we have our little trick, our little mnemonic is the cardiac arrhythmia bypass. So we draw the heart, we have the atria on top, cardiac arrhythmia on the middle, and bypass on the ventricles. If I want an anti-arrhythmic drug from the class 1 that tackles the ventricles better, I'm going to pick one from the class 1B. If I want an anti-arrhythmic drug from the class 1 that tackles the atria better, I'm going to pick one from the class 1C. And basically we have your class 1A that they can work on both things. Remember your quinidine with Brugada, remember disopyramide with the hypertrophic cardiomyopathy, and remember your procainamide with the Wolff-Parkinson-White. I hope this is helpful. Have a great day.